Well, hello, everybody, and welcome back to the fourth and the final MRV Patient and Family Forum for 2022. I think they've left the best till last, if I do say so myself. We've got a fantastic lineup of panelists today, and I hope that everyone out there will get a lot out of today's session. So today, firstly, I'm Dr. Pasquale, or Paddy Barbaro, as everyone calls me. I'm a paediatric haematologist at the Queensland Children's Hospital in Brisbane. And I have an interest in the diagnosis and management of inherited bone marrow failure syndromes, amongst other things. So today's session will be on ribosomopathies, particularly focusing on Diamond-Blackfan Anaemia and Shwachman-Diamond syndrome. But before I start, I'd just like to pay my acknowledgements to the traditional owners of the land that we are all on here in Brisbane. It's the Turrbal people. So I wish to pay my respects to their elders, past, present and emerging, and all First Nations elders of other communities who may be with us today. Sessions like this don't happen by themselves, and thankfully we had some very good sponsors who have supported not only these sessions but also Maddie Rivolt's vision over the few years that Maddie's vision has been with us. So I'd like to acknowledge the Victorian State Government, whose generous funds allows Maddie's Visions to host these forums. Also thanking our platinum sponsors, the Royal Melbourne Hospital Foundation, for their generous support for these sessions. Our honorary sponsors who generously supported MRV through the year, so that's Dexus, Carmen's Kitchen and Flavorite, and we very much appreciate all of their support. So we've got a fantastic lineup of guests speakers tonight. We will be doing a question and answer session at the end. So I encourage everyone out there, if you think of a question, please use the Q&A tab at the bottom of your screens to write the questions in. I will go through the questions and collate them, and then we'll go through as many questions as we can at the end of the session, in the question and answer session. If we can't get through your specific question, I will forward that on to the relevant person. Hopefully they can get back to you. You can submit questions with your name in them, or you can submit them anonymously. So please feel free to ask as many questions as you like. It will be great to get some good discussions happening at the end. So I'll move on to our first speaker. So the first talk is probably the most important talk of the session. We'll be hearing from Lena Stanley, who is a patient with Diamond-Blackfan Anaemia, who I've been fortunate enough to know over the past few years. And it's really important to hear patients' experiences and learn from patients as to what they expect and what they think is important for not only themselves, but the future of their condition. So Lena was diagnosed with Diamond-Blackfan Anaemia when she was 30 weeks pregnant with her first child. She was diagnosed through genome testing, and the finding of the RPL11 mutation in Lena certainly explained a lot of the issues Lena had through her years, and I'm sure you'll hear about those soon. But it also brought up some concerns for Lena's unborn child at that time. So I'd like to introduce Lena to talk about her experience with Diamond-Blackfan Anaemia. Also to mention Lena's position. So Lena is, she works as an occupational therapist in age disability community care. So it'll be very excited to hear her perspectives from not only a patient perspective, but also from a healthcare professional perspective. So thanks very much, Lena.
evening, everybody. Lovely to see you all, and thank you for the introduction, Patty. Firstly, I just want to apologise. I'm sick, so hopefully I won't cough too much while I'm chatting to you all. But I'm very excited to have been invited here this evening to share with you all a little bit about a patient's perspective, and please bear with me, of Diamond Blackfan Anaemia. Can everybody, I hope everyone can see my screen. If you can't, then please do let me know. My slides are going to be super basic, just a way for me to prompt what I'm thinking about as I talk. So lovely to be here, and thank you everybody for inviting me along, and I hope you'll enjoy my little chat. Thank you for letting me know it's working. So I'm Lena, I'm 35 years old. As Patty said, I'm an occupational therapist. I work currently for Anglicare, a community non-government organisation working in community age disability care. I've been there for 12 years now. Prior to that, I worked in a hospital in North Queensland. I love my job. It's difficult at times for lots of reasons. The sector's underfunded. You will all have heard about the Royal Commission into aged care. There's lots of things going on there. But it's very worthwhile, and I'm blessed to spend time with the patients that I spend time with every day, and also have a fabulous team of colleagues working around me. Excuse me. In my, I'm going to say spare time, I'm a Girl Guide leader as well. I've been a Girl Guide leader for 17 years. And before that, I was a guide as a youth member for 8 years. I currently work with a group of girls who are aged 10 to 14 years old. I also manage the district that we work in, or that I volunteer in, and there's 35 girls in that district as well. I always say guide leading is my second job, maybe I should say now my third job, and I love being a guide leader. I love the experiences that I had as a guide, and then being able to give those back to the future, which is really important. Also an avid crafter and baker. I don't always have a lot of time for that anymore, but and a wife. I'm also a mum to Miss 3.5. And I'm relatively recently pregnant and with twins, which is a bit of an unexpected twist in our reproductive journey, but it's very exciting and we're looking forward to it. And to say that I'm tired a lot of the time would probably be an understatement. We're a very busy life here, but I don't think I'd have it any other way. How is this relevant to this discussion this evening? Well, I also have Diamond Blackfan Anaemia, and as Patty said earlier, I was only diagnosed with that when I was 30 weeks pregnant with my daughter, which was only 3.5 years ago, and it certainly brought up a lot of unusual questions to be asked at that point in pregnancy. So taking a little bit of a step back, I was born in Launceston, Tasmania in September 1987. There is no history of any medical congenital problems on either side of my family. It was an exceptionally big surprise when I was born with a bilateral cleft lip and palate, which they spotted straight away on my birth. Big surprise for everybody. I also was born with a congenital cardiac defect. So I had a partial pulmonary anomalous venous drainage, which wasn't picked up until I was 6 months old. And up till that point, I was deemed as a failure to thrive baby in and out of hospital. Feeding was a real issue because of my cleft palate. Lots of issues. I was a very unhappy little baby. And eventually, they figured out that I had heart problems and sent me up to Melbourne, because of course in Tasmania there was no paediatric services in the late 80s. And I had my first open heart surgery in Melbourne. Now at that point, I also have a hypoplastic thumb, right side. Now at that point, they also referred me for genetic testing, but genetic testing in the 80s wasn't what it is today. They told my parents possibly some abnormality. Mum and dad both carried, uncertain, no family history of any of my conditions on either side for multiple generations, and my mum's been a genetic researcher for a long time, so she was aware of 4 or 5 generations back on both sides of the family. So just a bit of a black sheep. In I'm going to come back to later life shortly. As a child, once they'd fixed all my bits and bobs, relatively unremarkable. I was sick a lot of the time, but we lived in cold Tasmania. Lots of kids were sick there. Also had lots of problems with, just didn't seem to have any energy running around much. I hated going for walks. I hated PE. Did really enjoy dancing. So I did dancing for a long time. Maybe it's because it was structured, I'm not sure. But ultimately, until my teen years, I never really had, or at least there's never anything recorded, any other anemic type symptoms. In my mid-teens, I had a history of passing out or having really awful cramps and dizziness and lightheadedness and lots of things that they just attributed to me being a girl, and it wasn't ever really further discussed. In my earlier childhood, they'd done some more tests, decided it was just a random genetic mutation, 3% chance of passing on to any children I had. Just deal with it, move on. In my early 20s, it was discovered, and please forgive me just 2 seconds while I, hang on. In my early 20s, I then also had a run of low hemoglobin, which nobody seemed hugely worried about. Again, just put it down to my being a girl, or a woman at that point. Was flagged a few times, but nobody ever really investigated it too much. And I also then had just some routine cardiac monitoring, which discovered I had a secondary cardiac block, which was going to require a pacemaker. And at that point, I was living and working in Townsville Hospital. And so from a professional point of view, I'd spent a long time working on the cardiac unit and working with other patients my age or of a similar age with cardiac issues. So it's quite an interesting thing to step back and reflect and be the cardiac patient. And as it turns out, I think, as with most health professionals, I'm a terrible patient. Don't like being told what to do at all. So recovery was always a little bit difficult. They discovered they couldn't put a pacemaker in though. So as it turned out, my infancy surgery had occluded my SVC. And so we had to go in and have another round of open heart surgery in my mid-20s to correct that, rebuild my SVC and put a pacemaker in. And at that point, everything seemed fairly stable. My hemoglobin was a bit low. Nobody was really worried. Living a normal life, tired all the time anyway, but that was normal. I just carried on. Nothing really stopped me from doing too much. As I said previously, I had no diagnosis in my childhood. Genetic testing wasn't what it was. I saw lots of genetic specialists, but nothing really came from any of it. No history of other mutations, no history of any congenital issues. So we just kind of moved on with our lives. In 2017, I started trying to have a family with my now husband. After we lost a couple of pregnancies early, I insisted on a referral for genetics health to see if there was any congenital reason or any genetic reason why I was unable to carry any child. And of course, Genetics Health Queensland has an exceptionally long waiting list. So I waited and waited and eventually paid to go privately, where they did a basic battery of tests, told me that actually the chance of passing on my genetic stuff was closer to a 50-50 chance. Kind of thought maybe that might have been why I'd miscarried. No real firm diagnosis. And I needed to keep waiting for Genetics Health Queensland so I could get my full genome sequence done. Please forgive the coughing. In late 2018, I finally fell pregnant again with my now 3.5-year-old daughter, and I finally got an appointment with Genetics Health Queensland. And because I was pregnant, they very kindly rushed my genome sequencing, which usually takes 5 to 6 months. Came back in 5 weeks, which was very exciting. And at 30 weeks pregnant, age 31, I was advised that I had a mutation to my RPL11 gene, with a subsequent diagnosis of Blackfan Anaemia, which explained all of my other issues. So it explained my cardiac history, explained my thumb, explained my cleft, and now at 30 weeks pregnant, we're kind of investigating a little bit more about this hemoglobin issue. I've had a blood transfusion by this point already to kind of pick my hemoglobin up a little bit and get me through pregnancy. And we'll get this diagnosis. And the first thing the genetic counsellor says to me is, I think you need to test your baby because I think you need to consider late-term termination, which was a little bit confronting, if I'm being completely honest, because I lost a couple of babies and I was 30 weeks pregnant with a baby that they had kept an eye on through scanning, didn't have any cleft issues, didn't seem to have any cardiac issues either. Certainly that's not the only markers of Blackfan Anaemia, but they were my two big worries at that point. So it's quite a confronting thing to be presented with. I told her very politely that I wouldn't be doing that and that we could get some more discussion about what happened with diagnosis for my daughter if and when the time came after she was born. Now, about 3 weeks later, as soon as I had that diagnosis, the specialist team at the Royal started keeping a much closer eye on the unborn child. About 3 weeks later, they told me that it looked like she was anemic as well, with a 50-50 chance of being a false positive. Not wanting to take any chances, they said, I think we probably need to get her out. And so my daughter was born at 33 weeks, premature, and did very well in the nursery, was tested straight away as well. And I think it took a couple of months before those results came back, and she was also subsequently diagnosed with the RPL mutation and also then diagnosed with Blackfan Anaemia. So bear with me, please, for 2 minutes. I think I've already talked a lot about this already. I like to have a good old chat. Bear with me. I will come back to talk about my daughter in a little minute. So since I've had her, I've been seeing the haematology team up at the Royal Brisbane, initially 6 monthly after she was born, and they did a spinal tap and just to see exactly what was going on, and it looked like most things were working as they should be, which is great. So I've been seeing them annually, and everything is fairly stable. My hemoglobin has stabled out, which is great. Since I've become pregnant again, I have been seeing them fortnightly up at the Royal, and I will probably have a blood transfusion, at least one, before Christmas, and maybe some more after that, while we sort this pregnancy out. But aside from that, treatment is as it is. I mentioned about my treatment for my cleft, both repaired in my infancy, everything fine there. I'm a functioning member of society, not a problem. My cardiac stuff's mostly sorted and stable at present. Can't do anything about that. It's a bit funky, a bit shorter than the other one, doesn't really work so well, but I'm right-handed and we work around it. So the next generation. My 3.5-year-old daughter was also tested in infancy. They did a full genome sequence for her. She also has a mutation, was diagnosed with Blackfan. She doesn't have any of my symptoms. Her heart's fine. She's got a mild murmur, but her cardiologist said that's innocent. No cleft. Her thumbs are fine, although a little bit hypermobile, I suppose you might say. None of the other midline things that traditionally go along with Blackfan, and Paddy is very kindly keeping an eye on Mia. Annually we go and see him just to keep an eye on things. As far as I can tell for her, we'll probably carry on seeing someone for the rest of her life, especially given the chance that she may then pass that mutated gene on to any children that she might have. But aside from that, so far so good. She's doing well. She's a thriving 3.5-year-old, keeping us on our toes, and probably part of the reason that I'm still a very tired mama. And any other parents out there will know exactly what I'm talking about. My tiredness isn't all Blackfan related. Current pregnancy, proceeding much the same as my previous one did, although this time around, they're twins, so we're keeping our eye on things a little bit more closely. But B, I know a whole lot more this time than I did last time. I didn't have a diagnosis. I didn't know what I was doing last time around. This time we have a diagnosis. I'm being monitored for my hemoglobin. Everything else is being looked at. As we scan the twins at their routine scans, they're being carefully looked at as well. We've chosen not at this point to do any testing for either of them while they're in utero, just because the condition is so variable. You know, a positive test doesn't necessarily mean that one or either of them are going to have life-limiting conditions. You know, it could be very much like my daughter already, who has the mutation but otherwise is totally fine. And yes, I also know that there's a chance that they could have the mutation and actually be very unwell, but there's not a whole lot we can do about that while they're in utero. And certainly I think at this point we wouldn't want to do anything about termination while they're in utero anyway. So lots of really big topics to be discussing at this time of the evening. Sorry, everybody. So keeping an eye on things, and when they're born, they'll be tested. Certain Paddy and his team will take over looking after them if required when the time comes. My clinical practice. Sorry, just very briefly. I expect we're going to have monitoring on and off for the rest of my life. For someone who's been unwell and been monitored her whole life, this is not really anything unusual, to be honest with you. I just becomes part and parcel. I think I'm not too bothered. I think also being a health professional, it definitely puts a spin on things that you wouldn't necessarily have if you weren't a health professional, which probably leads very nicely into this next topic. As I said before, I'm an occupational therapist. I've been in the community for 12 years. I love my job. Definitely things about an NGO that could be better, but overall it's a good place to be. In terms of impact of my condition, I'm tired all the time. Part of that is because Miss 3 doesn't sleep particularly well. Part of that's because my hemoglobin is not so great. It just is how it is. I've been tired for a long time, probably for the majority of my life. If I let it get down to me, I would just spend all day in bed, and that's no way to live. So I just kind of carry on a little bit. As an OT, I'm more aware of things like energy conservation techniques, and so that's it's quite useful. And in my late childhood, I spent a lot of time with speech and drama, working a lot on relaxation and focusing. And in terms of my clinical practice, that's certainly a good way of managing how I live so that I can carry on working and being a productive member of society, which actually is quite an important role for me. I actually don't have any clients in my care with DBA. I've never met anybody, aside from my daughter, who also has it, although I did reach out to a few other parents and other people living with the condition by Facebook when I was first diagnosed. I think ultimately the important things that guide my clinical practice here would be the same for any client anyway, or any patient anyway. You know, everyone's the same, we'll treat other people the same. I suppose the big things are about energy conservation and that sort of thing. I think also the clientele that I work with, generally speaking, either wouldn't have been diagnosed because the diagnosis wouldn't have happened at that point in their lives, or they just haven't made it to me yet. So maybe that will come in the future. So I don't have a whole lot to talk about in terms of my clinical practice, rather than saying that things like energy conservation would be a really good place to start if and when the time comes. Advice for other patients or parents of patients. I suppose ultimately, I found it quite nice getting a diagnosis when the time came. It explained all of my unusual things and gave me a little bit more of a guide of what was going to happen, you know, why things had happened the way they had happened and what might happen in the future. So for me, I find that really useful. I think that perhaps I'm a little bit unusual in that I was diagnosed so late in my life, although I'm sure that there are other people out there who are diagnosed at equal times. And I suppose one of the really big things that really stood out to me when they were first talking to me about DBA is that it's such a variable condition. There's so much variance in how it presents. Just because you've got a diagnosis doesn't mean to say that it's not manageable. And certainly there's risk associated with the diagnosis, as there's with lots of things, but it doesn't necessarily mean a life sentence. You know, even for my daughter, it doesn't mean a life sentence. And yes, we'll keep an eye on her, but actually that's a good thing, because if we're keeping an eye, then at least we'll know what's happening. And ultimately, the really big thing that I always say to my clients, and that I want to pass on to you, is to ask questions. If you don't know, you won't know. If you don't ask, you won't know. And certainly, like, there's plenty of information out there on the internet about DVA, but how it relates to you or how it relates to your child is going to be completely different in every instance. And so the best people to be asking are things like your specialist team. Maddie Revolt's Vision are probably a good place to start for information as well. You've got to ask the questions, otherwise you won't know the answers. And I didn't think I was going to talk for as long as I have. I look forward to any questions that you might have at the end of this evening. And again, thank you for having me along.
Fantastic, thank you, Lena. And I'll expect some baking next time Mia comes to chocolate.
I'll do my best. I don't get to as much of it as these days, although Mia is much better at helping these days than she was.
Oh, fantastic. And if you're tired now, wait till you've got another 2.
Oh, I know. Gosh.
It'll be
interesting.
Yeah. So, look, thanks, Lena. I think Lena's story highlights a lot of interesting, features of these ribosomopathies, the variability from patient to patient, even within families, the diagnostic kind of dilemmas, and how we're, diagnosing patients a lot more through genome sequencing these days, and also highlights, the multi-system impacts that these conditions can have. So thank you very much, Lena, for an excellent opening discussion. So our next speaker, I've known for a long time, Dr. Adam Nelson, who's currently the staff specialist in BMT cellular therapies at the Kids Cancer Centre in Sydney. I first met Adam, he was my resident way back when. We were both doing a paediatric hematology oncology term at Sydney Children's Hospital. And look where we both are now. I'd like to think that my influence was the reason why Adam, is where he is today. But
it's all you, Penny. All you, Penny.
Thank you, very good. So look, Adam's done some amazing things over the years. So Adam's spent 7 years at one of the world's leading centres for bone marrow transplant, inherited bone marrow failure syndromes at Cincinnati Children's Hospital, where Adam was on faculty there, developing expertise in the diagnosis, management of these conditions. He did research into the pathogenesis of marrow failure syndromes and management of those conditions. He was also the BMT lead for cellular therapies and the principal investigator for multiple CAR T-cell treatments for leukemia, as well as developing novel CAR therapies for infections in patients with bone marrow transplant. And we're very lucky to have Adam back in Australia working with us, and he'll be talking about stem cell transplantation in ribosomopathies tonight. Thanks very much, Adam.
Thanks, Paddy, for that very nice introduction. And Paddy's always been as nice to me as he is tonight when we were training together. It's very hard to follow such a great talk by Lena, who was very generous in sharing her insights and experiences, living with the disease. So I'll do my best to follow on. As Paddy said, I work in Sydney, but spent a number of years overseas in Cincinnati Children's Hospital, and Paddy will introduce her, but we're so fortunate to have another expert from Cincinnati joining us tonight, Professor Cass Myers, who'll be speaking a bit later on. And in case Paddy doesn't mention it, we'll send a special shout out to her because it is 3 a.m. Cincinnati time. And so we're very appreciative for Cass giving up her time to speak to us in the wee hours of a cold Cincinnati morning. So I'm just going to do my best to give you a bit of an overview about stem cell transplant. I'm not going to go into too much detail because it's such a different thing for each patient and is so variable for each patient and the indications and the complications. But I'll just try and give you a bit of a flavour of how we decide who needs a transplant and how we go about that. So, you know, for people who aren't familiar, what do we mean when we say stem cell transplant? Well, there's two types of transplants we talk about, autologous and allogeneic, and basically they're just fancy ways of saying, do you get your own cells or do you get someone else's cells? And for these conditions, we're talking about getting stem cells from someone else. And stem cell transplant in general is used to treat quite a variety of different conditions. The indications for transplant, certainly in the years that I've been doing, have changed over time. So it's quite exciting to see the science evolve, and that, you know, fortunately, there are some conditions that we no longer need to transplant as much as we used to. But again, then we're also discovering new things that require stem cells transplant. So, you know, we obviously want to replace the patient's own stem cells that are defective with those from a healthy donor. And that can either be a donor from within the family. There's a 1 in 4 chance that a sibling may be a match to the patient, or more commonly, we're using unrelated donors such as adults who are registered on worldwide registries, or cord blood that has been stored in umbilical cord blood banks. We generally need to, what we call, condition the patient, and that's to give them some sort of therapy to get them ready to receive the new stem cells. And that requires some chemotherapy, usually, plus or minus some sort of what we call serotherapy, or agents that are designed to suppress the patient's immune system so it doesn't reject the new stem cells that it recognizes as foreign and allow them to grow and repopulate the blood and immune system. Now, stem cell transplant, you know, is a big deal, and we don't do it unless we absolutely have to, because we're very aware that things can go wrong during the transplant process. And there's a whole list of things, and that talk in itself can go for many hours. But the sort of main things that keep us up at night are things like the stem cells not growing or graft failure, worrying whether the immune system will recover to a full extent to allow the patient to fend off infections later on. Infections that can occur during the acute transplant process when we've artificially suppressed their immune system, so the patients are at risk of infections. And then another feared complication called graft versus host disease, where the new cells that are growing recognize themselves as being in a different environment and can attack the patient. And then obviously there's the long-term monitoring that goes on for patients who've had a stem cell transplant. And that's one of the beauties of working in the stem cell transplant field, is that we get to monitor our patients for a very long time afterwards and see them do very well. So I'm sure that others will go into much more detail about this than me, but just to give you a brief overview of what some of the ribosomopathies are, in particular Shwachman-Diamond syndrome to start with. It's a quite a wide ranging disease, with patients affected as early as the first few weeks of life, all the way through to adults that are diagnosed with Shwachman-Diamond syndrome when they don't present with the classical symptoms. But what we sort of think about when we think about Shwachman-Diamond syndrome are those patients who are presenting in the first 12 months of life with what's described as failure to thrive. And that's because they have problems with their pancreas and can't absorb calories in the right way. And so you often see, when you look at their growth chart over time, highlighted here, that they're not quite growing along the normal percentiles that we expect to see in other patients. And when we look for reasons behind that, and patients may also present in infancy when we check their bloods, usually with neutropenia as the first sign of Shwachman-Diamond syndrome. And we look for different genes that are involved in ribosome maturation and ribosome processing, and have what's been known for many years is some of the common mutations in the SBDS gene. But as the field's evolved and we're learning more and more about this disease, we've discovered novel genes that are also implicated in Shwachman-Diamond syndrome. And I'm sure as we screen more and more patients now that genetic testing is more routinely available for patients who present with what's thought to have some sort of genetic basis, we'll discover more and more genes as time goes on to add to the list. Shwachman-Diamond syndrome patients may or may not have a number of different features apart from the pancreatic and blood count problems. We can see congenital anomalies present at birth, sometimes some skeletal dysplasia that can be picked up on routine imaging. They often have abnormalities in the liver function test and can have neurodevelopmental anomalies that may not be present until you assess for those during schooling age. Now, why do people like me see patients with Shwachman-Diamond syndrome? Well, we know that they're at risk of bone marrow failure or transformation to things like myelodysplastic syndrome or rarely acute leukemias. So what's the problem that we see in terms of the marrow? Well, our bone marrow is a very heterogeneous organ that's responsible for making all of our blood cells. And what we commonly see is that the vast majority of children with Shwachman-Diamond syndrome have some sort of neutropenia, but it may not be there all the time. It may come and go. They also have defects with the way that the neutrophils work. And so the neutrophils, although they may be low or normal in number, do not function the same way that normal neutrophils will. So these patients are at risk of infections and we need to keep a close eye on them. Patients may also have low platelet count, which can make them more prone to bleeding and bruising. And obviously the thing that we worry about is that the problems in the bone marrow can continue to progress and lead to what we call transformation. And that's where the cells become dysplastic and don't work in the way they normally should. And this is often thought to be a precancerous syndrome. And so we need to intervene early. Now, there's lots of different ways that we look at the cells and we can look at the genes within the cells and look at some of the problems that are happening within the cells. And over time, Cas-Myers and large international groups have shown that there are abnormalities that are common in patients with Shwachman-Diamond syndrome. And in any other patient where we might see these changes in the cells, it may make us think that these cells are changing and might be becoming pre-leukemic or leukemic. But in patients with Shwachman-Diamond syndrome who've been followed for many years, these changes, and when I talk about these changes, I'm talking about changes in chromosome 7 and chromosome 20, do not necessarily mean that the cells are going to change and become leukemic. Now, but we do know there is a risk of these cells changing to become leukemia, and in large series that have been reported, that can happen anytime around the age of 12 years. So how do we treat Shwachman-Diamond syndrome? Well, some patients may need no treatment. They may have mild low counts that get better with time. Some patients require antibiotics because we know that their neutrophils don't work in the right way. We can give hormones to try and stimulate the neutrophils, such as G-CSF, to help in times when patients may be at risk of infection, or to try and keep their neutrophil count at a nice, safe number so they're not at risk of overwhelming infections. Different other therapies have been tried, but not with great response. So the only cure from a blood point of view for Shwachman-Diamond syndrome is a bone marrow transplant. Now, when this was first being investigated, the outcomes weren't great because of lots of toxicity related to the transplant itself. And over time, as we've studied more and more of these patients, we've improved the way that we do transplant. We've improved the supportive care of transplant so that we can recognize when patients may be at the right time to need a transplant and not waiting until they've developed either that pre-leukemic MDS state or frank leukemia, which is much harder to treat and much harder to transplant. So what are the indications for transplant? Well, I put the caveat that this is all relative because every patient is different and there's lots of things that go into this decision, not only from the transplanter's point of view, but also from the family's point of view. It's important to have these discussions. Obviously, if the bone marrow stops working completely and we see low blood counts across the board and patients are requiring transfusions with either pack cells or platelets and having low neutrophil count, then that's a good indication to move forward with transplant. If patients have progressed to develop the pre-leukemic myelodysplastic state or frank leukemia, then that's also an indication to move forward with transplant with some sort of therapy beforehand. Or if we see changes in the cells that are either persistent or progressive, and in that they're acquiring new mutations and we're seeing more and more cells with those changes, that may make us think that we need to transplant before they transform into full leukemia. But remembering that there are those specific changes that we see in Shwachman-Diamond patients that don't mean you need a transplant, such as those chromosome 7 and 20 changes. Then there's a whole bunch of other things that go into the decision about transplant. what donor can we use? If we're using a family member, it's very important that we screen that family member to make sure they're not an asymptomatic affected Shwachman diamond patient. We want to make sure all the organs are in good shape to go ahead with transplant, that there's no infections, and then discussing fertility issues that may be relevant for the patients. As I've said, actually the majority of patients don't actually require a transplant. So, only about 20 to 30% of Shwachman diamond patients will require a transplant during their lifetime. However, when they do need a transplant, they have obviously a more severe form of disease, meaning that their bone marrow stopped working at an earlier age, and so often are transplanted in childhood. We know that there are better outcomes if you're transplanted for pure bone marrow failure rather than having those pre-malignant or malignant cells that have developed. And when we think about the types of cells that we like to use, we prefer bone marrow compared to peripheral blood stem cells because that is associated with an increased risk of graft versus host disease. As I mentioned earlier, we know that patients who were transplanted years ago who had the full, what we call myeloablative type chemotherapy compared to reduced intensity chemotherapy did worse. And so we now know that it's better to give what we think is less toxic chemotherapy to get patients through transplant on the other side. And then we're always thinking about what other strategies we can use for those patients who have developed MDS or leukemia to try and reduce their disease burden before going on to transplant. And there's lots of new agents around that have been investigated that don't require that full-blown chemotherapy before you need a bone marrow transplant. Thinking about diamond Blackfan anemia, well, we know that this is another ribosome problem that results in what we call red cell aplasia. So just not having enough hemoglobin floating around doesn't tend to affect the platelets or the neutrophils, but it can in a small percentage of patients. As we heard from Lena, there's quite a variable phenotype in how this affects patients, and some patients may not be diagnosed until adulthood when people have put all the things together. We also see other congenital anomalies such as craniofacial abnormalities, skeletal problems, genitourinary abnormalities, and cardiac abnormalities. And the timing of performing these surgeries, if they do require surgical correction, is important because many of these patients will end up on steroid therapy, and that has implications for how the wounds heal with these surgeries. So sometimes patients may not be started on steroid therapy if they have an upcoming corrective surgery. There's also a cancer predisposition with DBA, and most cases are diagnosed within the first year of life because babies present with, lethargy and pallor and poor feeding because of their profound anemia. When we look in the bone marrow, what we see is the bone marrow looks essentially normal. There's just none of those red cells or red cell precursors. And then we can look for some of the genes, but important to look for all causes of bone marrow failure in patients who present with red cell aplasia. Briefly, how do we treat? Well, we replace their blood essentially for the first year of life to maintain a good hemoglobin to allow growth and development for the babies. There's risks associated with getting blood, such as iron overload, so it's important to monitor for these things, and most people end up on some sort of chelation therapy to reduce the iron burden. The mainstay of treatment for many years has been steroids, and that works in the majority of patients, but doesn't always last. We like to delay the start of that therapy until 1 year of age because we know that in that first 12 months there's such a need for growth and neurological development of infants that can be impacted by steroids, but it can be started earlier if there's indications. There's usually a 4-week trial, and if that doesn't work, we often do a trial again, 1 to 2 years later, because the patients may have a subsequent response if they didn't respond the first time. And then obviously we want to make sure they respond and then get to the lowest dose of steroid possible to prevent long-term complications of steroid therapy. But they need lots of supportive care and vigilance to look for side effects. But if that doesn't work, then patients may be considered for a bone marrow transplant. And there's a nice article that sort of goes through how we should think about thinking of candidates for bone marrow transplant. So patients who have severe iron overload, we know that their risk of transplant-related complications is much higher, so we need to get that iron down with various mechanisms. before we consider them for transplant. If patients are under 10 years of age and have a sibling donor available, then we think those are a good group of patients to have a transplant. Or if they're 12 years of age, greater than 10 years of age and have a donor available, then we can have a discussion about transplant, but may not always be indicated because there's other things to discuss and be wary of in the transplant process. As I said, sibling donors are superior compared to unrelated donors, but over the years, as you can see by these two graphs here, using unrelated donor stem cells is catching up to be almost equivalent to matched sibling donors due to the way that we transplant in our supportive care. We've traditionally used a myeloablative approach in DBA, although there's some emerging evidence that reduced intensity can be effective in certain patient population. And as I said, there seem to be better outcomes in those children treated less than 10 years of age, probably because they have less iron on board, which can impact the transplant. There's lots of transplant-associated complications, and I'm conscious I'm almost out of time. So it's not a benign procedure and really does require a long discussion between the family and the transplant physician to see if the timing is right and if the risks are acceptable to the patient and family. I'll just quickly mention, viruses are a big problem in transplant and something that we've worked on quite a bit in my time in Sydney and overseas. And I just wanted to mention some emerging therapies that we have. We know that because of the immune suppression that we cause by doing a bone marrow transplant, that viruses can be a significant cause of both morbidity and mortality during transplant because we don't have the normal immune cells there to fight viruses. So there's different types of immune cells, particularly the T cells, that can fight viruses, and we rely on those to keep viruses under control, but during a transplant, those are not present. So can we use the T cells to fight viruses artificially? And what we've sort of developed along with others is a way to get donor T cells, chop them up, sorry, not chop up the cells, chop up the viruses of interest and present those to the cells in a test tube so that we train these T cells to fight the viruses that we know that can cause problems after a transplant. And these cover the common viruses that we think about, including EBV, CMV, adenovirus, and BK virus. And over a number of years, colleagues of mine and I have worked on this, and what we've developed is a T cell therapy to treat viruses post-transplant. And this is quite novel because we've been using this upfront instead of traditional antiviral medications, which don't work that well often and have a lot of toxicity. And I just want to give you one example of a patient that I looked after who had Fanconi anemia, who developed CMV virus post-transplant. And we didn't want to use antiviral treatments because she had poor renal function going into the transplant. And what you can see here, these hollow circles, is the level of the virus in the blood. And this line here is when we gave the T cells. And what you can see is this is a measure of T cell activity. So these T cells increased, which corresponded with a decrease in the virus count. So that the virus went away and stayed away. And these T cells hung around and performed sort of viral surveillance in this patient. So she didn't need any traditional antiviral therapy and avoided lots of toxicity and was a long-term survivor. And just to mention that late effects are common and need to be thought of in the post-transplant period. So hopefully what I've shown you is that ribosomopathies are a complex disorder that requires multiple different experts from hematologists to surgeons to endocrinologists to fertility experts to come together to do a true multidisciplinary care of these patients. There's lots of novel therapies that are emerging that may potentially delay and hopefully one day prevent the need for transplant. The indications for transplant are variable and quite patient dependent and need to take into a lot of factors, and that these transplants should be performed in centres with expertise in the management of these marrow failure disorders, and that we need to follow these patients up for a long time. So thanks for your time, everyone.
Thank you, Adam, for that excellent run through of a very complicated topic, and it's good to see, new therapies coming through. And it's with these sort of new therapies, new approaches, that transplant is really becoming just safer and safer as the years go supply, and really is now a viable option for most patients. So I'd like to introduce our next speaker, Dr. Amy George, who's the Research Fellow at the John Curtin School of Medical Research in Canberra. Amy is a member of the Maddie Revolt's Vision Centre of Research Excellence, and she's currently working on an MRV funded project looking at identifying therapeutics which can be repurposed for the treatment of myelodysplastic syndrome and bone marrow failure syndromes. Her research interests continue to focus on the ribosome, particularly ribosome biogenesis, and also ribosomopathy, specifically Blackfan Anaemia. And she's also interested in the role of ribosomes in cancer biology. So she'll be talking to us today about the Australian research update in the ribosome field. Thanks very much, Amy.
Great, thank you, Patty, for the introduction. I'll just share my screen. Hopefully everyone can see that now. Great. All right, before I begin, I'd like to acknowledge and celebrate the traditional owners on whose lands we meet. So in Canberra, it's the Ngunnawal and Ngambri people, and pay my respects to elders past, present and emerging. As Patty mentioned, I'm here to present a bit of an update on the types of ribosomopathy research that we're conducting here in Australia. I just wanted to start by disclosing I'm a laboratory scientist by training. I'm not a clinician. So if you have any questions about therapies, please refer those on to your clinician. I'm also not paid by or financially sponsored by any commercial entities, including pharma. I really wanted to start tonight by talking about what ribosomes are. And I like to think of ribosomes as being the protein factories of the cell. So this little schematic here really introduces the concept of ribosomes. Andrew Deans and Tracy Bryan have quite wonderfully introduced the concept of what genes are. Genes are encoded in our DNA. I like to think of them like a recipe book. And every time we need a protein to be synthesized by the cell, we essentially photocopy that recipe. Along with the amino acids, these both enter into the ribosomes. And so the ribosome can then put together these amino acids into particular sequences to make proteins. So ribosomes themselves are made up of ribosomal proteins. I think of these as the bricks of the ribosome, and holding together these bricks of ribosomal RNA, which is slightly different to messenger RNAs in that they don't actually code for anything, but they act as scaffolds to hold the bricks together. So just thinking about what that actually looks like, on the right-hand side here, we have a schematic of an ADS ribosome. So this is a ribosome that would be translating mRNA into protein. You can see it's very colourful. There's lots of different colours in there. Every individual colour represents a different ribosomal protein. There are around 80 different ribosomal proteins in a ribosome. So our cells really require many ribosomes to carry out normal processes. So this ranges from sort of general housekeeping processes right through to proliferation, cell growth and cell division. We have about 10 million ribosomes per cell, which is pretty incredible when you think about it. But some cells do have an increased demand for ribosomes, in particular blood cells. So because blood cells are being turning over quite frequently, we need to have increased ribosome biogenesis to be able to manage that. So the process of ribosome synthesis, which we call ribosome biogenesis, it takes place primarily in the nuclei of cells in a structure called the nucleolus. So in this image here, we're able to stain the nuclei, which contains your DNA. And inside that are these green dots, which are the nucleoli. And so these are lipid droplets that are full of proteins, RNA, and even DNA that help to establish ribosomes. But these structures are also really important for cellular stress sensing. So if a cell determines that not enough protein synthesis is being carried out, the nucleolus will elicit a stress response to the cell to let it know that it needs to make more protein or do something about it. So I guess the fundamental question we have is what causes ribosomopathy? So this is, I guess, is quite a complex answer or question to ask, but essentially like to think about it in terms that there are alterations in genes required for ribosome biogenesis, which modify their formation and function. So these can be mutations in ribosomal proteins, so the bricks of the factory. the ribosomal RNA associated factors. So these are factors that are needed to make ribosomal RNAs and process ribosomal RNAs, so making of the mortar. Ribosome associated proteins, so like to think of, so we need to have multiple accessory proteins in cells to be able to build these ribosomes. So we like to think of them as the factory construction workers. And of course there are other genes involved, which I won't talk about tonight. But what do these changes actually do? So they can actually prevent ribosomes from forming, and this reduces, of course, the overall protein production in cells. But in some cases, you can actually still form ribosomes, but it can actually change their structure, and so it can actually change the types of proteins which are made. So I guess this particular image is a little bit complicated, but I just wanted to sort of step through it quite generally. I just wanted to show you that the process of making ribosomes is actually quite complex. There's a lot of different steps. It usually starts off with the formation of ribosomal RNA up here. So there are ribosomal DNA repeats. So we have genes encoding ribosomal DNA, which are then transcribed to ribosomal RNA. We have factors in our cell that cut this ribosomal RNA down. So basically molecular scissors to make it into a format that can actually bind to the ribosomal proteins. So we have two different types of ribosomal proteins, classes of ribosomal proteins, small subunit ribosomal proteins, RPS, and then RPL, which is associated with a large subunit. And so these integrate into pre-40S and pre-60S subunits, which are then further matured to make the ADS ribosome down here. So this ADS ribosome attaches to the mRNA and translates it into protein. So I just wanted to make the point here also is that different stages of ribosome biogenesis are associated with different ribosomopathies. So in the case up here, we have Treacher-Collins syndrome through the RNA processing, X-linked dyskeratosis congenita. Down here where we're assembling the ribosomal subunits, cartilage hair hyperplasia and DBA. And then of course down here, which is right before protein translation, where this process is being checked by the cells, we have a Shwachman diamond syndrome. So this is also quite a complicated table, but really just as an overview of what I say the most common ribosomopathies. There are of course a number of others that aren't on this slide. Predominantly all of these ribosomopathies in this table are associated with some level of bone marrow failure, apart from Treacher-Collins syndrome. As Adam quite eloquently discussed in the previous talk, talked about all the clinical features of a lot of these ribosomopathies. In this particular case, I've got a research interest in Blackfan Anaemia. And of course, this is caused by alterations or mutations in ribosomal protein genes. And so there's quite an extensive list of associated genes. In particular, we have an interest in RPS19, which accounts for around 20 to 25% of cases. And as Adam mentioned, these are associated with macrocytic anemia, congenital malformations. Again, there can be quite a spectrum, of course, and also, unfortunately, an increased predisposition to both blood and solid tumor, blood cancers and solid tumours. So back in 2013, the Captain Courageous Foundation, which is now part of the MRV, established the Australian Blackfan Anaemia Research Program. So this program was really established with researchers that were spanned the breadth of Australia, but we also now have international collaborators involved. And we're basically a group of multidisciplinary researchers that have different levels of expertise that help to address some key questions that we wanted to answer. So these experts were ranging from people that have expertise in blood disorders and cancer, ribosomal proteins, drug screening, as well as genetics. And so the main goals of this particular program were to be able to conduct genomic and functional analysis of individuals or families with DBA recruited from Australia. And then secondly was a very blue sky. A goal was to be able to identify new therapies to support the treatment of DBA. And so one of these studies, which was led by Dr. Parvati Venugopal, who was part of the MRD steering committee of this seminar series, where we were able to recruit a family with an affected DBA child. And at that time, they didn't know what the particular mutation was. And so part of this study, we were able to conduct whole genome sequencing to identify the mutations. So there was a loss in chromosome 12q, which contained a number of genes, but it also included RPS26 and RPL41, which are ribosomal protein genes, as well as a variant in the SPDS gene. And so we're able to conduct functional analysis of that. We're also developing cell models from this family and also other families to be able to conduct functional analysis to understand what actually happens to cells when we have these particular mutations. Of course, my area of expertise is probably more in the therapeutic space. So we really have an interest in identifying alternative treatment options for bone marrow failure. These have been quite limited to date, and Adam has not quite nicely introduced that already. So just wanted to make the point here that, as he mentioned, steroid therapies are available for those who respond, but patients can become refractory over time. Of course, there's also the stem cell transplant, which can be undertaken and where it's possible and when appropriate. But more often than not, patients undergo chronic red cell transfusion for their entire lives. And so that requires a lot of high-level clinical management. So our goal is really to try and identify new therapies and supportive therapies for the management of this bone marrow failure in DBA. But how do we actually go about doing this? So I guess for us as scientists, we're quite interested in the molecular pathogenesis of DBA, so understanding what the mechanism is to go from mutation in ribosomal protein gene through to actual bone marrow failure. And so for us trying to understand that process, we can then help to develop therapies to support that. So really the focus of our program has been around an observation which was published back in 2011 now, which was of a study by Ben Ebert's group from the US. And they were able to show in bone marrow from patients with Blackfan Anaemia an increase in a protein called P53 in the bone marrow. The P53 is actually a tumor suppressor protein, so it's involved it's actually quite often mutated in cancer. But in this case, it's highly activated, and that's indicative of a stress response that's happening in the bone marrow. And so what we've been doing and what has since been published is many papers supporting the notion that there's an increased stress response in the nucleolus, which I showed you in the first couple of slides. That particular structure is eliciting a stress response that's causing this bone marrow failure to occur. So for us, we can actually take quite a reductionist approach and go back into the lab and generate some very, let's say, artificial models where we can take cells and deplete them of RPS19. We do that using a technology called RNA interference, which essentially interferes with RPS19 messenger RNA and stops RPS19 from being produced in cells. So we can actually do functional analysis, and what that entails is that we can actually look at the ribosomal subunits, so the 40S subunit and the 60S subunit. In this case with RPS19, it affects the 40S or small subunit. So when we deplete it out of cells, we can see a reduction in 40S, so we know that the 40S subunit is not being made. We can also then look at the cells underneath a microscope, and we can stain for different parts of the cell, in particular the nucleoli, which are in red here. And so when we deplete cells of RPS19, we see this dispersion of nucleolin staining, which indicates that the nucleolus is undergoing a stress response. And then subsequently, to follow that up, we can use an approach called Western blotting, where we can isolate protein from the affected cells and look at P53 expression. And so what we see is an increase in P53 protein when we deplete RPS19. So based on this, we're able to expand our study to look at all of the 80 ribosomal protein genes that are expressed in humans. And so this is a paper we've recently published. And so we're able to assess that around 79% of the ribosomal proteins that we tested have increased P53 when we deplete them out of cells, including the majority of DBA-associated genes. Of course, RPL5 and RPL11 didn't induce P53, and the reason behind that is that these particular ribosomal proteins are quite important for this stress response, and so if we deplete them, it actually stops the response from happening. But unfortunately, patients with these mutations can actually undergo bone marrow failure through slightly different mechanism. So based on this, we were able to conduct high throughput screening to look for therapies to be able to treat DBA patients. So to try and distill 7 years of work down into one slide, we've been able to take the cell models that I've shown you in the previous slides. We've been able to conduct biomarker screening. So what that entails is that we test around all of the individual genes that constitute the human genome. There are around 18,000 different genes. So we can test those all out individually to see whether or not we can inhibit the stress response. We've also conducted drug repurposing screens, so around 3,500 FDA-approved drugs. So the premise behind that is that these therapies are already out there in clinical use for other conditions. And so can we actually take some of these therapies and repurpose them for the treatment of DBA? And of course, have another couple of novel drug development projects that are ongoing. We can't do these studies without the appropriate tools. So we use these plastic microplates. So you might see here that have individual wells. And so we can actually test different conditions in every individual well with this plastic plate. So we can do that for thousands of different conditions. And we also need robotics and high throughput screening equipment to do that. So this is my lab at ANU that helps to facilitate this type of research. But of course, when we identify therapies for the treatment of disease, in particular DBA, we want to be able to evaluate these in appropriate models. Of course, we need to evaluate these in the bone marrow compartment. And so it really helps us to ascertain whether or not what we've identified is going to be an effective therapy. It's also really important for us to collect that information to be able to step into clinical trials. So how do we try and do this in a laboratory environment? Well, we can actually culture bone marrow cells from individuals, although this is actually quite challenging because obviously with bone marrow, they can be quite sparse sometimes and we can't culture the cells particularly well if they're undergoing failure. So how we get around this is we've been developing genetic preclinical models. These are animal models of ribosomopathies that help us to model the bone marrow environment. We also are moving now into using human-induced pluripotent stem cells, which again, Andrew and Tracy quite nicely introduced the last few sessions for therapeutic testing. So in terms of the genetic models we have for DBA, we're able to effectively give mice bone marrow transplants with the affected cells, affected bone marrow, and then we can actually treat with drugs. So just to show you, these are individual mice, and in the DBA affected mice, we see a reduction in red blood cells. We also see a reduction in this pre-CFUE stage of erythropoiesis, which is where the DBA defect usually occurs. We're able to then do FDA-approved therapy testing, so we can take our cell model and we can look for drugs that are going to inhibit this stress response. So we identified a number of drugs that were worthwhile for us to pursue. And this takes quite a lot of time. We move these into our in vivo mouse models of DBA. And so for drug 1, which we tested, we were able to ascertain that it was having a partial response in the bone marrow when we tested it, which was quite exciting for us. So I just wanted to finish by talking a little bit about new technologies. I'm sure Professor Meyer will be talking a little bit about this as well. But for us, really, we want to develop new therapies. So we want to develop new small molecule inhibitors. So that takes a long time. It's a long process. Again, as it's been previously mentioned, there's opportunities for gene editing to correct the genetic mutation in patient HSCs. And also have an interest in mRNA therapy. So think about the COVID-19 vaccines that have been developed. We can utilise that type of technology to be able to possibly assist with the bone marrow failure as well and reversing that. Of course, I also have an interest in evaluating novel therapies in better humanised models. We want to try and get away from the animal models. And so with the iPSC models, with sophisticated technology like 3D bioprinters, we can start to print the bone marrow niche and be able to do our therapeutic testing in those types of models. Of course, we can also develop humanised animal models as well. So with that, I'd just like to thank a lot of people that have been involved over a long period of time in this particular research. And I'm very happy to take any questions during the chat session or afterwards. So thank you for your attention.
Thank you, Amy. And it's amazing to see what research is going on right here in Australia in these conditions. Fantastic. Thank you very much. So I'd like to especially thank our next speaker, Associate Professor Cass Myers, who's joining us all the way from cold Cincinnati. It's very early in the morning there, so I want to do a special thank you for Cass for joining us today. So Cass is the Division of Bone Marrow Transplant and Immune Deficiency at Cincinnati Children's Hospital in the US. She specialises in treating patients with bone marrow failure and hematopoietic stem cell transplant for non-malignant diseases, with a special emphasis on Shwachman-Diamond syndrome and dyskeratosis congenita. Her research interests focuses on translational and clinical studies into leukemogenesis and bone marrow failure related to particularly those two conditions. In addition to her clinical work and research, Cass is the co-director of the North American Shwachman-Diamond Syndrome Registry, from which we have had a lot of excellent data produced. So Professor Myers is going to talk to us today about updates in diagnosis, management and emerging therapies in ribosomopathies. Thanks very much, Cass.
Hi, everybody. Thank you for having me here today. I really am looking forward to chatting with you. Please tell me if you can see my screen, and, or let me know if you can't see my screen.
No, that's perfect. Thanks.
Great. So as I said, thank you for inviting me here to speak today. And sorry, I'm on a different computer than I usually am, so it's a little slower to advance. Yes. So I'm going to start with a case today of an 11-month-old that I saw in marrow failure clinic who had a prenatal diagnosis of short ribs and skeletal dysplasia. He had short long bones, and this small chest wall that he had resulted in him having small lungs as well. He was noted to have syndactyly of his toes, which you can see in this picture here, as well as failure to thrive that required a G-tube. And you can see his growth curve there. He was found to have pancreatic insufficiency that required enzyme replacement and did, though, have normal blood counts. He had normal genetic testing for some of the syndromes associated with his skeletal issues, but due to his pancreatic insufficiency, he was tested for Shwachman-Diamond syndrome and was found to be homozygous for one of the most common mutations in the SBDS gene. And so this patient, of course, does have Shwachman-Diamond syndrome, and I'll focus my talk today on some of the new updates for patients with SDS and share some data from the North American SDS Registry, which, as you've heard, I lead with Akiko Shimomura in Boston, that hopefully will inform care practices and potential treatment approaches. Dr. Nelson covered this quite nicely, so I'll kind of do this quickly, but the majority of patients with SDS do have autosomal recessive mutations in the SBDS gene, but about 10% lack a known mutation. There is a slight predisposition to having more male patients affected, although we're not sure why. And the classic presentation includes intermittent neutropenia, diarrhea, and failure to thrive. The pancreatic insufficiency, which causes this diarrhea, resolves in about half of patients by age 8. And characteristically, patients do have short stature, skeletal abnormalities, and sometimes chest wall abnormalities. About half of patients have congenital anomalies, and neurodevelopmental issues are quite common. This is a ribosomopathy, which is why we're talking about it today. And the SBDS proteins promote joining of the 40S and 60S ribosome subunits. More recently, in the last few years, new genes causing SDS-like diseases have been identified, such as SRP54, DNAJC21, and EFL1. And unfortunately, as you heard, patients with SDS do have a high risk of developing MDS and AML, and that risk is somewhere between 10 to 30% in the first 4 decades of life. Greater than 15% of patients do have some transient or persistent bone marrow clonal chromosomal abnormalities. The most common are listed here. As Dr. Nelson mentioned, some of these are quite common and not concerning in patients with SDS, while others do warrant further investigation and intervention. Just briefly considering the management of patients with SDS, which is largely supportive, neutropenia can be treated if there are severe and recurrent infections with chronic GCSF therapy, although that's unusual. Other therapy is mostly supportive, including transfusional support as needed and pancreatic enzyme and vitamin replacement therapy. I'm going to focus my talk today on exciting new data that informs malignancy screening and surveillance in our SDS patients. And then finally, as you heard and was nicely covered, the definitive treatment for the blood complications of SDS, including aplastic anemia, MDS, and AML, is stem cell transplant. But both the transplant itself and MDS and AML require very special approaches in patients with SDS because standard treatments are quite toxic. We often hear from families that the blood complications of SDS are not a major part of their daily life, but rather other issues, the GI issues, neuropsych components may take a front seat on a daily basis. But the blood complications can be very serious and are often without symptoms. And this is why we're focused on this today. The true risk of marrow failure, MDS, and AML in Shwachman-Diamond syndrome remains unclear. We think that there are a lot of patients, especially with milder phenotypes, who go undiagnosed or may develop MDS and AML in young adulthood. It's challenging to predict who of our patients will develop these blood complications and when. And the blood complications can be very high risk even without symptoms. As was mentioned, they do require special treatments. And unfortunately, this is the leading cause of severe medical complications in patients with SDS. There are opportunities, however, to intervene before severe disease develops, and that's why it's so important to keep this in mind. So this is very basic, but I wanted to make sure we're all on the same page. So what is myelodysplastic syndrome? This is a pre-leukemic condition caused by the development of abnormal blood cells. Characteristics of MDS can include lower blood counts or changes in your blood counts, an abnormal appearance of cells in the bone marrow, and the development of abnormal chromosomes in the bone marrow, or the development of mutations in genes in the blood cells of the bone marrow. This can then move along to leukemia, which is a cancer of white blood cells that results in uncontrolled growth that crowds out the normal blood-producing cells in the bone marrow. And in patients with SDS, the particular type of leukemia that is most commonly seen is AML, and that is generally true across most of the inherited marrow failure syndromes. On the left, you'll see there is a normal bone marrow with lots of different types of cells. And on the right is a leukemic bone marrow with predominantly the same leukemia cell type. So through the registry, we recently looked retrospectively at blood complications in our patients with Shwachman-Diamond syndrome and found that severe bone marrow failure requiring a transplant generally develops in younger patients. And this is typically in patients less than 5 and really almost less than 2 or 3 years of age. MDS and AML, however, typically develops in teenagers or young adults, but this is not uniformly the case. MDS and AML, unfortunately, as I said, are the leading cause of mortality in our SDS patients. It's about 80% of mortality in our registry cohort, and this highlights the need to develop better detection and better treatments for our patients. I do have to say that the next part is a bit difficult to talk about and tough to hear, but it's important to frame our understanding of what we're facing in order to overcome it. So recently, the SDS registry, with myself and Akiko shown here, led a multi-center effort of over 18 centers worldwide, looking at outcomes of patients with SDS and MDS or AML. On the bottom axis here, you'll see is time from diagnosis, and on the vertical axis is survival. As you see on the right, AML has very little survival with current treatments. And this doesn't mean we can't treat it. We do have survivors, but it is very tough to cure. Standard treatments don't work because they're either toxic for patients with SDS or the leukemia just doesn't respond. So we need to figure out better treatments. But until that happens, our best chance really to beat this is to intervene and catch it before it happens, before the AML develops, and treat with a stem cell transplant, which replaces the sick bone marrow cells that are starting to head towards AML with healthy new bone marrow. And that's what Dr. Nelson covered quite nicely. Importantly, this study also identified that there's a survival advantage in patients undergoing active marrow surveillance compared to those who are not. So switching gears a bit and focusing on surveillance specifically, we often are hear, I feel fine. What's the benefit of bone marrow surveillance? Leukemia is very difficult to treat, as you've just seen in patients with SDS. But survival is excellent in patients transplanted before the leukemia develops. So it's really important to not wait for symptoms. Many people won't feel sick until after leukemia develops. And what we've seen in the registry is that mild or normal blood problems do not lower the risk of leukemia. The risk of leukemia remains the same despite the level of blood count abnormalities. We also hear a lot, we know of people who had surveillance and still develop leukemia. Why bother getting a bone marrow? So I'm going to share with you a story of a young girl followed over many years of time. And each one of these bars, vertical bars, is a different year of bone marrow examination. This young lady developed a chromosomal abnormality called isochromosome 7, which is quite common in patients with SDS, and by itself, not a significant problem. And you can see here it stayed over many years and then it went away. But after it went away, her bone marrow started to look a little funny. She developed dysplasia. And very rapidly after that, she developed MDS, just as she was heading into a transplant. She was part of the SDS registry, and we were able to look back in time at these bone marrow samples that she very kindly sent to the registry and started applying new technology that didn't exist at the time of her original testing. And these are genetic and genomic studies. And we were able to detect using these new sequencing technologies that after her chromosome 7 disappeared, there was a new clone, a genetic change that developed that we couldn't detect with our old technology of testing. But now with this new testing, we could see this clone growing and acquiring more and more mutations over time, as you see here. And then just before it developed MDS, she developed this NRAS mutation. So what I'm trying to highlight here is we have new surveillance technology to add to what we've been using previously. And while surveillance didn't work for this patient, we have this newer technology available. And now we may have detected this clone much earlier and be able to intervene. Is it perfect? No. We can't say that we can detect everything before it happens, but it is much, much better than historically what we were doing before. And we are finding these clones earlier in our patients that we could not detect previously prior to the development of leukemia, which improves outcomes. So how is this surveillance improved? This is through data and samples from the registry kindly donated from our participants and their families. And this work, again, was led by Akiko Shimomura, initially in collaboration with Dan Link there on the left, but further looking at pathways into leukemia development with our leukemia expert, Coleman Lindsley, and a lovely, talented postdoc, Alyssa Kennedy, who were looking at pathways that we see in patients with SDS with and without leukemia. So in order to explain this, I want to first remind you that you can be born with mutations in all the cells in your body. And so people who have Shwachman-Diamond syndrome have these mutations and are affected in all the cells in their body, and that's there on the right, compared to non-affected people on the left. But what can happen in someone with SDS in their bone marrow cells, all of which already carry the SBDS mutations, the cells can acquire additional mutations, shown by that X there, in a single bone marrow cell, in another gene. And in certain circumstances, depending on which gene develops this mutation, This cell can then multiply and give rise to more cells with this additional mutation and start to grow out. In certain circumstances, this will evolve into a leukemia. And Alyssa was able to show that in patients with Shwachman-Diamond syndrome, commonly mutations are developed in two genes specifically, and this is EIF6 and TP53. Alyssa, again, guided by Coleman and Akiko, used these registry samples and went into the lab and did a lot of work, much of which I'm gonna not talk about today, but looked specifically very closely at these EIF6 and TP53 mutations in the bone marrow to better understand and predict leukemia development. And here I'm representing the bone marrow as a car, and our bone marrow cells have a journey or a road they take to mature and produce healthy blood. And that it sort of is the normal way. But what happens in SDS is the bone marrow gets stuck. It fails along the road and can't finish the journey to produce blood cells. And that leads to low blood counts and bone marrow failure. When the cells acquire mutations, if they get a TP53 mutation, this TP53 mutation gives more gas to the stuck bone marrow car, but it shifts off into a dangerous journey, moving off the standard road into leukemia, which obviously we don't want. In contrast, if EIF6 mutations develop, this gives gas to the bone marrow car in a healthy way, improving how the ribosomes work and restoring bone marrow function, and without the progression to leukemia. And this is sort of helping it along the right path where it can function better with improved blood production. So these cells with EIF6 mutations don't seem to progress to leukemia. We've not yet seen that happen in the registry. And this is a potential new target for therapies. And there are lots of folks working on this across the world, including through the registry. But this is an exciting area where potentially new therapeutic treatments may evolve. So of course, it can't just be that simple, right? P53 mutations are not good. TP53 is a gene that makes a protein whose job it is to prevent tumors from forming. It's called a tumor suppressor gene and is a guardian of the genome. And is very important. And when it's mutated, tumors can form more easily. So what happens in SDS bone marrow cells is they develop TP53 mutations often, but usually only in one of the two copies of TP53 in a cell. So everybody has two copies of this TP53 gene. And again, it's very common in SDS early in life to develop a mutation in one of the two TP53 genes. And this can hang around for years and be stable. And that is not in and of itself an indication for a bone marrow transplant. However, what Alyssa found is that in some patients, they develop a second mutation in the same cell. So they have not one, but two TP53 mutations in the same cell. And this is the point where disease becomes high risk and can lead to leukemia. And this also is the point where we have an opportunity to intervene. Unfortunately, the issue is it's very hard to detect the difference of two TP53 mutations in two different cells versus having them be in the same cell. Our current testing for sequencing is in bulk. So we sequence all the cells together, and we don't have the resolution to distinguish if the mutations are set in separate cells or together in the same cell. This increased resolution requires what's called single cell sequencing, which is now only available on a research basis. It's quite time intense and quite expensive, and is not really clinically available anywhere that I'm aware of at the moment. So we're working on ways to better develop this type of testing, as well as how to use the current resolution of testing to guide patients' care. This is an example of where the registry hopes to serve as a resource to the medical community for how to understand their bone marrow results, because the understanding of this sort of genomic testing is advancing at a rapid pace. We formed an SDS board, which Akiko, Shimomura, Coleman Lindsley, myself, and we've also recruited Chris Riley, another adult leukemia expert in Boston, to work, are working together with physicians to discuss their patients' bone marrow results and what those findings might mean. We can share this knowledge and information from the registry as well as our own clinical and scientific expertise to help guide decisions. What we can't do is give specific medical advice about patients that we haven't evaluated or seen ourselves. But really it's meant to be a partnership with the local treating physicians to both help individual patients, but then also help learn across the field of how to better approach and better use these genomic results. Finally, I get very often, can't we do surveillance on a blood sample? And the short answer is we don't know. Blood does not assess for abnormal appearance of bone marrow cells, which is one of the earliest findings that we can visually see. And it typically does not catch early chromosomal abnormalities as well. The sensitivity of this is unknown, and so it's not clear if some of these early mutational changes could be caught in blood testing as well, but this is an area that we're actively researching. So kind of in summary of these results, TP53 mutations are very common in SDS, and single TP53 mutations can persist in a cell stably for years without progression to leukemia. However, 2 TP53 mutations in the same cell is highly associated with leukemia development in patients with Shwachman-Diamond syndrome, and really is an opportunity for early detection with surveillance and intervention. Cells with EIF6 mutations have not yet progressed to leukemia and don't seem to be to induce leukemogenesis. These are our current registry surveillance recommendations, and we are hoping to put together a clinical document with these guidelines to share with physicians and families. We do recommend regular blood counts, although those alone are not sufficient because, as I've said, even patients with really mild blood count abnormalities remain at high risk of leukemia. Bone marrow examinations are critical, and it is important to note that at least through the registry, what we've seen is that the testing done on bone marrow evaluations is not always uniform across all centers. We do recommend both morphology to look at how the cells look, cellularity for marrow structure, cytogenetics and FISH to look at chromosomal changes, as well as flow to look at maturation patterns. And then the newest addition, what I was just talking about now, is somatic mutation analysis to look for these mutations such as TP53. We do recommend annual bone marrow evaluation due to this high risk, but these decisions are really a partnership between physicians and families. So looking forward for our patients with SDS, I hope I've shown you that there's some great work done with the help of our patients and families to find improved markers for early identification of high risk and impending leukemia. And there is work in this area in other marrow failure disorders such as Fanconi anemia, and telomere biology disorders that I'm aware of. But we do need novel approaches for treatment of both marrow failure, MDS, and AML in Shwachman-Diamond syndrome and other marrow failure disorders. Some promising agents include hypomethylating agents, or forgot to list venetoclax there, as well as small molecules that are in development. Gene therapy is in its early stages, although there are folks investigating that as well. And then really one of the ways to do this is through multi-institutional clinical trials that include patients with SDS. And there are several transplant-related trials, both for marrow failure as well as MDS and AML in this setting. So I'd like to thank all of our collaborators and registry teams in Cincinnati, Boston, Colorado, and MD Anderson. And of course, Akiko, who's my partner in crime in all of this work, and most importantly, our patients and families. And thank you for your attention, and I look forward to your questions.
Thank you very much, Professor Myers, especially considering the hour it is over there. So we'll go to our question and answer session. So I just invite all of our speakers to come back. And firstly, I'd like to just thank all of our speakers. We've had some excellent talks tonight. So thank you to everyone who spoke tonight. So if I can just get all the speakers just to turn your cameras back on, but just your microphones off, and just turn your microphones on when you're speaking, that'd be great. So look, I'll ask the first question to Lena. So this is from Laura, who's a genetics health worker, and she asks, she says, thank you for sharing your story, and she just asks, she was interested to hear how do you think we can better support journeys of patients to diagnosis, who go through genomic sequencing diagnosis? How can we help support you through that journey and discussing, things like family implications? What was the process that you went through, receiving those genomic results? Were there any problems? Could you give any ideas of how we could do it better?
Thanks for your question, Laura. I think it's difficult without knowing too many other adult DBA patients, but I think my situation was rather unique that I got my diagnosis while I was pregnant. It certainly have been much more helpful to have been able to get the genomic sequencing done before I tried to fall pregnant again, which I did attempt to do, but wasn't successful in getting there. How can it be more helpful? We did, after my daughter was born, we did have a couple of appointments for genetic counselling about DBA and implications of that for future pregnancies and future children. And at the time, that was really interesting. But we then embarked, and I didn't mention this in my talk, sorry. We then embarked on a 2-year IVF journey, which didn't really give us a whole lot of viable embryos. The original discussion was that we might make some embryos and then send them all off for testing, and then the ones that didn't test positive for Blackfan could come back, and we could implant those. But some other fertility issues popped up for me, and I really didn't ever make enough embryos that would make it worthwhile getting them tested. And we made the decision just to go ahead anyway. So we did receive some counselling. I think probably the one thing that really would have been useful is if I'd been able to get the genomic sequencing done earlier. And I don't know what it's like in other states or in other countries, but certainly in Queensland, I didn't rate very highly on their priority tool. So it was almost 2 years waiting for an appointment there, and we didn't have the money to pay for it to be done privately. So, maybe working on getting that done sooner might be an option. I'm not really sure. Sorry, I don't know if I've answered your question, Laura.
Thanks, Lena. Yeah, I think we're working hard. I mean, I think everyone everywhere who works in these sorts of fields are trying to implement genomics into, frontline clinical practice rather than having to wait for specialist genomics sort of appointments. So we're really working towards trying to incorporate those into upfront diagnosis. Look, I might direct this question to Adam from Karen Savage. What are the sort of current recommendations for surveillance in patients following transplant? Is it different to other patients undergoing transplant?
Yeah, that's a great question, Karen, and it's probably a whole talk in itself. But I guess, we think about it in different stages. Transplant for things like DBA and Shwachman Diamond syndrome will fix the blood count abnormalities and risk of progression or development of leukemia, but it won't fix the other cells in the body. So there's still those other things that we have to be careful to look for, such as the cancer, other solid cancer predisposition that's associated with those conditions. So that's one sort of aspect that we continue to follow. And then there are the transplant-specific complications that we continue to monitor for a long time post-transplant. And I guess the frequency of how often we do that depends on how the transplant went and if there were any acute complications. But over time, we would eventually see patients less and less frequently, but still continue to monitor for those transplant complications. And, I think there's been a lot of work done over recent years to say, yes, there's lots of things that we know about, such as pulmonary disease and eye disease and vascular disease that can occur, but it's important to screen for those before they become symptomatic. So we're getting better at doing lots of screening tests at regular intervals post-transplant to monitor for those transplant complications before they develop symptoms, because it's much harder to treat, lung disease post-transplant by the time you're already breathless or hypoxic. So again, it's a bit of a cop-out answer, but it sort of depends on how the transplant went. But yeah, definitely there should be some regular follow-up to look for not only disease-specific complications post-transplant, but also the general complications that we know are important to screen for routinely. And also we like seeing our patients regularly long-term, so you never get away from us that easily.
Thanks, Adam. I guess, Amy, one question, I guess, Lena's story highlights the variability in these conditions. Has there been any clues from, the lab research as to some of the things that underlie that variability that we see from patient to patient, even in families who have the same underlying ribosome mutation?
Yeah, no, it's an interesting question. I think there are a lot of modifying genes that we don't know about that are impacting on the response that we see. Of course, as I mentioned, we know with specific ribosomal proteins, they are predisposed to stress response, whereas others aren't. So that's also something that's really interesting, and that's a key area that we're actually trying to actively research, understanding why specific mutations lead to certain types or phenotypes and others don't. So that's, yeah, definitely a hot area in our area of research.
Thanks, Amy. Look, Cass, I'd like to ask you a couple of questions. This one's actually from Dr. Addy, who's joining us from the UK today. So welcome from overseas. She asked, in a patient, presumably a patient with Diamond-Blackfan who's on long-term steroids with some Cushingoid features, potentially, iatrogenic diabetes, what would you recommend for checking of skin diseases if they have fragile skin? And she also asks, can Shwachman-Diamond patients present with early ichthyosis, associated dermal and epidermal lipid droplets and hypoglycemia before other manifestations of Shwachman-Diamond syndrome present?
Sure. I think relative to the first question on skin issues in chronic steroid use in DBA, I would say that similar to any patients on chronic steroid therapy, there is, a significant risk of having more fragile skin, as she said. And I don't have any specific recommendations as far as monitoring from a dermatologic standpoint other than symptomatically. And I'm not aware of any increased risk of other skin conditions, although over time they do have a slightly increased risk of developing skin cancers. And that is data from the DBA registry. As far as patients with Shwachman-Diamond syndrome, there are a couple of patients in the registry who do have had ichthyosis as part of their presentation. So that is something that in the setting of other, if other symptoms concerning for STS would arise, that would certainly sort of raise a red flag in that regard.
Thanks, Chris. Just a quick question from me. So, I have a few patients who have ribosome mutations, but don't have any other, phenotypes really, and normal blood counts, normal MCVs. Do they have Diamond-Blackfan? Are we doing them a disservice by giving them a diagnosis, or, do we need to have a different term for those types of patients?
That's a great question. And, you know, it's hard to answer given the variability of Diamond Blackfan itself. Because, you know, there are sort of, as you said, within families, asymptomatic carriers that, you know, are they truly affected or not? And so, you know, I think it would sort of depend in the clinical context of how this patient's mutation was diagnosed. If they're a family member of somebody who has actual a phenotype, a DBA phenotype, then I probably would at least have the discussion of monitoring them similarly to their family member, especially relative to long-term issues that are sort of manifesting through the DBA registry, such as risks of colon cancer and esophageal cancer that come in sort of late teen and early 20s, because that's sort of a very simple screening process. But yes, that's an excellent question, and I don't think can be clearly answered.
Fantastic. So I'm not alone. That's good to know. So I guess, Adam, this one, Aliska Furlong brought this up, and I had the same thought. You know, given that you know, transplants outcome is better if you're younger. You know, in patients who are stable on you know, medical therapies, GCSF, regular transplant, who are well chelated, you know, what do you think the role of transplant is there, and how often do you think those sorts of patients should, you know, meet and see the transplant team to discuss options of transplant?
Yeah, it's an excellent question, and this is the problem with you know, registry data, is that, you know, when we pull everything together, and we certainly have shown this in the FA population as well, that, you know, if you're transplanted at a younger age with just marrow failure, you do better than if you're transplanted at an older age with even with marrow failure or with other clonal abnormalities. So, but again, that's pulling all the data together. So that's why I say, you know, transplant is an individual decision that needs to be taken into account based on every patient's clinical situation, but also, you know, other factors that are involved in terms of what are the donor options. You know, if you have a matched sibling donor, then that sometimes makes the decision a little bit more clear, not always 100%. But if you're struggling to find donors, then that also takes the decision out of your hands. And then, you know, as you said, you've got to think about other things that go into that transplant decision-making process, not just iron overload, but, you know, has there been a history of C-diff infections? Has there been a lot of problems related to steroid therapy? Has there been alloimmunization from chronic red cell transfusion therapy? You know, all these other risks that need to be involved. So yeah, so that's the misleading thing with looking at the data, is to say, well, you know, if it looks better less than 10 years of age, is there really a difference if I transplant my patient at 9.9 years of age versus 10.1 years of age? No, but it's probably, that's to your point, having these discussions early with the transplant team, even if it means that you meet them once and then you don't see them ever again, or you don't see them for 5 years when transplant options emerge again. But I think having those conversations, so everyone's well informed. Plus, we're all type A as transplanters, and we want to know all the options available to us. So for us to know what donors are out there is very helpful, rather than trying to scramble at the last minute to try and find a good donor when transplant is more urgent because you've got associated chromosomal or impending MDS or AML developing. I think, yeah, always happy to have discussions early, and then never see us again. We never take offense in that.
Yeah, look, I think it's worth patients, even stable patients, keeping in contact with the transplant team. New things come up, new questions come up. You know, so I always try and get them to see the transplant team at least once every 1 or 2 years, just to have a bit of a chat. You know, I don't think my transplant colleagues like seeing patients who are very well, you know, for a chat, but, you know, I'm not sure.
I think it's nice to see patients who are well in the transplant clinic. Sometimes it's a nice change.
I would echo that.
Lena, look, can I ask, you said you sort of haven't met other patients with Blackfan anemia. I guess, you were diagnosed as an adult, so you're able to go out and do sort of your own research, your own investigations. Have you come across anything that's been particularly helpful for your understanding? And do you think a sort of a wider sort of community of patients support will be, beneficial?
Honestly, Dr. Google has so much information on it, doesn't it? It's very easy to fall down that rabbit hole. I don't know is a short answer to that question. I have mixed feelings about it. As a parent of a child with Blackfan, I think that actually it might be nice to connect with other parents of other children. But, me as asymptomatic, is going down that path a good idea? I'm not sure. As an adult, I've been connected for a very long time with the Heart Foundation and have some contacts there with people who have congenital cardiac issues who are adults, and much the same. We had a collect group when I was growing up. We all got together and chatted amongst ourselves. And I don't know is the short answer to your question. Maybe it might be useful. Maybe it might not. Maybe I don't know until I've tried. There is a couple of Facebook groups out there, and I did reach out initially when we were diagnosed. I just can't for the life of me think of the genetic counsellor's name that sat us down and had a good chat with us about DBA at the time. And she linked us in a little bit, but I really haven't reached out. I suppose there's other things that going on in my life that have been more important, I'm going to say, in the short term.
Yeah, it's tricky, isn't it? I think, there's lots of other competing interests. Trying to find time to do research is often tricky. And I guess everyone knows what they need to do.
And actually, I did a little bit more quick reading. I was going to put some things in my presentation and I decided not to. It's such a variable condition. I feel like it's quite a rabbit hole again to go down that and think about all the things that can and could go wrong. And, do I want to know all that information at this point in my life? Maybe, because some information is useful, but actually I'd like to just carry on living my life without worrying about exactly what may or may not happen in my 40s, or, by the age of 50, I'm this percentage likely of having XYZ happen. I don't find that overly useful, but then that's just me.
Fair enough. I think it highlights everyone's different. So, some people want to know everything. Some people are happy just to sort of live their life and go on. So everyone's different, which is.
And I think I've had this much in my life with this many issues. I don't know anybody else who's had this many surgeries for a variety of different things. I think I'd rather just live my life now.
Yeah, fantastic.
But everyone's different.
Amy, can I ask, with your drug repurposing development sort of work, have you come across anything that may inhibit EIF6 as a sort of a treatment for Shwachman diamond? Or I guess, Cass, is there anything in the pipeline for blocking EIF6 as a sort of therapeutic target for Shwachman diamond?
Well, I can start. So I guess I'm not really specifically looking at that particular target, but I know worldwide there is a lot of interest in that target. So, and I know there are a couple of research groups actively developing targets or therapies for those targets.
Yeah, I am also aware of several groups of folks. Akiko and the folks in Boston certainly are working on that, but there are groups in I believe Italy and France as well, and potentially in England, I think, as well. So I think as many people as can work on it would be great, because it would be fantastic to find that molecule.
If EIF6 blockers could cure COVID, we would have it tomorrow. But
yeah, right. Yeah,
I think that's the case. Look, Alishka Furlong asked an interesting question. She asked sort of how far are we from getting gene therapy for Shwachman diamond and other inherited bone marrow failure syndromes in Australia? And I think the answer is we won't get them soon enough. Just looking at the experience of gene therapy in thalassemia. So, there is a registered product for gene therapy in thalassemia that was approved by the EMA, a couple of years ago, but unfortunately, no one would pay for it. So, it's been withdrawn from the European market. So I think the best we can hope for is some very good, gene therapy clinical trials coming to Australia, hopefully soon. And I know Andrew Deans is definitely working on one for Fanconi's, but his techniques that he's developing hopefully can be applicable to many other bone marrow failure syndromes. So hopefully through his work and work of many others, we might have some clinical trials up and running soon. But in terms of therapy for all, gene therapy for all, I think that's sort of a long way away. Cass, I don't know what's the experience in the US for sort of widespread gene therapy.
Yeah, I would agree with your comments. I think there's a lot of interest and certainly active clinical trials in sickle cell and thalassemia and some of the SCID primary immune deficiencies, as well as FA. I have a gene therapy trial for telomere elongation in patients with diskeratosis congenita as well. But there's a lot of hurdles to that. To expanding that therapy from a cost perspective as well, and so I do think it's a ways out, specifically for SDS and DBA. I'm aware of several people also in the U.S. working on that, not at the clinical trial stage quite yet, but in development.
Yeah, thanks. Look, we're sort of running a little bit behind schedule, but I'll just run through a couple of other questions. I guess maybe Cass or Adam could answer this one. What are the sort of current screening recommendations for patients with Diamond-Blackfan anemia, not Shwachman Diamond? How often, what should they do in terms of AML leukemia surveillance?
Right. The risk of AML, MDS and AML is higher than the general population, but not as high as some of the other inherited marrow failure syndromes for patients with DBA. And there will be actually some consensus guidelines coming out, I think sometime maybe in early 2023 from worldwide experts in DBA. But the regular bone marrow examinations are not recommended in patients with DBA who have stable blood counts. In the setting of changing blood counts or changing need for supportive care, certainly a bone marrow could be considered. As far as other malignancy screening, recent data suggests that patients with GBA have an increased risk, as I mentioned before, of colon cancer and esophageal cancer. And recommendations include colon cancer screening with colonoscopy starting in the early 20s or soon after stem cell transplant. And then if the screening is negative, then spacing that out as one might for standard colon cancer screening.
And what about solid tumor screening in Shwachman-Diamond syndrome?
Oh, sure. The risk of solid tumors in Shwachman-Diamond syndrome appears to be quite low. There are some single reports of breast cancer and I think it's a sarcoma as well as a pancreatic cancer, but they're isolated reports, and generally speaking, we don't recommend any standard screening for solid tumors in our SDS patients.
Thank you. Look, Karen Savage again, she's asked a few questions. A quick question to Adam: what's the availability of the viral specific T cells at the moment?
Yeah, it's a great question, Karen. They are available in Australia. There is an institute in Queensland who can provide them at a small amount of cost, but it does require looking at HLA typing of the patient to make sure they've got a matched unit available. I am in the process of working with my old colleagues in Cincinnati in getting some of those T cells shipped across so that we can open up access to that for patients in New South Wales and any other patients who can then travel to our centre to receive that therapy. We call it a drive-by therapy. They come in, get the infusion, hang around for an hour, and then can leave again. So sort of almost like getting your drive-through Maccas, but getting T cells at the same time. So yeah, we're hoping to have that available in the first half of 2023, at least in Sydney as well. But yeah, they are available in Australia, and certainly many people on this call and at other institutions have got access to those T cells through the Queensland group. There's also a lab in Westmead who have them as well, but it's a bit hard to access them because they're through clinical trials in the adult sector. But yeah, they can possibly be accessed at the moment.
Look, one final question just to Cass. Laura, again, she asked, how do you think single cell sequencing will change management, surveillance, treatment of patients with not only Shwachman diamond, I guess, all other predisposition syndromes?
I think when it's clinically available, single cell sequencing will be quite helpful. I think outcomes in general across inherited marrow failure syndromes are better when patients are transplanted earlier. If they are headed towards malignancy, and the issue is that most patients, or many patients, will never need that intervention, and so it's not something generally that we can offer sort of as a prophylaxis. And so I think being able to identify these high-risk patients early will vastly improve our outcomes. And there's some new data that we'll present at ASH from the SDS registry that demonstrates that actually, that there's a handful of patients that we have transplanted using not single cell, but simply NGS sequencing data, sort of with short interval repeats to assess the acquisition of additional clones and growth of clones within marrow in patients. And in patients who are having a rapid acquisition of new clones or rapid growth of clones who have been taken to transplant for high-risk concerns, outcomes are excellent. And so I do think that this is the way the field is headed, and that it will dramatically help our patients.
Yeah, thank you very much. Look, we've gone a little bit over time, so look, I'll just wrap up and say thank you to all of our speakers and panelists today. I think I think this was the best of the 4 sessions, if I do say so myself. So thank you to all involved, and thank you to the audience for coming along and listening. Look, I'd just like to introduce the Maddie Rewalt's Vision CEO, Amy Coote, who will officially close the 2022 Patient and Family Forum sessions for us. Thank you, Amy.
Thanks so much, Paddy, and thanks so much everyone for joining us tonight and attending our Patient and Family Forum session 4. I'm very proud to be the new CEO of Maddie Rewalt's Vision, and really do consider it an absolute privilege and honour to honour Maddie and the Rewalt family's legacy and lead the organisation into the future. So just a little bit about me. Over the last 10 years, I've held executive leadership fundraising and development positions within the for-purpose sector, which are preceded by more than a decade of business development and project leadership roles in the professional conference organising and events sector. I'm incredibly passionate about making a positive difference in the community and driving social change. During my time in the charitable world, I've led my teams to raise in excess of $25 million for vital causes, including medical research, youth mental health, cancer support, healthcare and education. I'm very much looking forward to working with our amazing team, board and committees to grow Maddie's vision and increase our impact even further, helping discover improved treatments and cures for bone marrow failure syndromes and enhance our critical support for patients and families. So over the past month, we've been thrilled to hold 4 very informative and fascinating sessions for our Maddie's Vision community on specific aspects of bone marrow failure syndromes, and we're sincerely grateful for everyone's support to make these events possible. Being able to bring together our patients and families with expert clinicians, allied health, researchers and scientists really strengthens our collaborative support network to improve patient health outcomes. An enormous thank you to our event sponsors for all of the sessions of our patient and family forums. So the Victorian State Government, Royal Melbourne Hospital Foundation, Alexion and Servia. Thank you to the Symposium Organising Committee, expertly chaired by Dr. Lucy Fox and assisted by Dr. Adam Nelson, Dr. Patty Barbaro, Professor Tracy Bryan, Dr. Belinda Go, Dr. Parvathy Venugopal, Professor David Ritchie, Judy Edwards, Mei-Ling Ye, and the MRV executive. I would also like to share a very special thank you to Jay Asoma and Lou Johns from my team, who have worked really tirelessly to bring these forums together. Now, we will be emailing you a short survey after the session. We'd really appreciate your feedback, as it helps to inform us as to how we can improve these events in the future. And you can also access the survey via the link posted in the Q&A box. Finally, thank you so much for joining our 2022 forums. We hope they've been informative and helpful. If you'd like any more information on Maddie Rewalt's vision, or would like to access support through our telehealth nurse service, please visit our website, mrv.org.au. Thank you all so very much, and I hope you have a lovely evening.